brilliant.
And then I wrote, how did you come up with the idea? But I know that now,
Yeah.
by running.
By running. Yeah.
And being intelligent, yeah. So why do we need prognostication?
I think there's lots of dimensions to that. First of all, it's important for patient information. It is about how do I live my life, how scared do I need to be, how worried or not do I need to be. It is also about making progress in disease understanding. So if we're going to figure out why some stay as enchondromas and some turn into dedifferentiated chondrosarcomas, we need to understand the disease in a different way than just giving them a grade and doing the surgery. And if we want to talk about the future and hopefully having treatment alternative to surgery, we need to understand it, what's going to work and what's not going to work. At the present time, we don't really have any effective treatment other than surgery. But if we're going to get there, then we really need to know, again, which little group are the ones that need that treatment or not so as to prevent side effects and morbidity from that treatment. So.
I also think that you got into some new interesting territories, like if it's in the humerus, etc., or femur, we can watch and wait. Even if it's a low grade 1 or ACT or enchondroma, it maybe doesn't matter. And if we have a local recurrence, it doesn't matter as much at all.
Yeah.
And
I think possibly we talked about numbers in some countries, and I think possibly even in our numbers, I think if anything, for the last few years, we've become more conservative. We've chosen to wait and observe more and more, and I think protecting people from overtreatment obviously is a huge responsibility. Putting someone in a general anesthetic, opening up their arm, making a big window, polling about, doing all this stuff is just, if it's not necessarily, we really need to know that from beforehand and avoid it.
In radiology, there are a lot of don't touch lesions. But in America, there are a lot of data on histology because they touch them. But they're benign lesions.
Yeah.
You shouldn't biopsy. And then you've written, the methodology should be simple to ensure low inter-observer variability.
Yes.
And that's good. And can you give some examples in radiology, for example? Variability between me and Ingeborg or someone else?
From other types of situations?
No, in chondrosarcoma, for example.
I think we've talked a little bit about features of radiological aggressiveness. And we talked in the thesis about that we keep wanting this one feature, which tells us whether it's an enchondroma or a chondrosarcoma, and we just don't have it. And instead we have to combine 5 or 6 or 7 features. And a lot of these features are describe something as, is it expanded, is it not expanded, how extensive is scalloping, how much is it influence the cortex. And these are descriptive, even though you can measure it in millimeters, often it is more descriptive. And when you have descriptive terms, there is always going to be interpretation and difference between authors. And even a simple thing, really, like drawing a line from one place to another, is definitely open to observer variability. But it's probably a better place to start than a mix of many other qualitative things.
Yeah, I agree. And I think this measurement of the soft tissue components, it sounds reproducible. So you have a cortex and the largest distance perpendicular. So if you can write down how to do it, someone else can do it. And that's part of material methods. Yeah.
Yeah, and I was inspired really by the cartilage cap from the peripheral chondrosarcoma by this article, is it Gaynart or something, that had the original article. So for the peripheral chondrosarcoma, ones that happen on this bony protrusion, it's a bit like a cauliflower, and the tumor is really just the top of it. And to correlate that to sarcoma, in that instance, they said that, well, they drew a nice diagram. You draw a line there, and you draw a line there. And it's really sort of instinctively simple and clear. And so that was a bit of an inspiration to it. So we sat down, Ingeborg and I, and said, how are we going to do this? And also you have to say that you have to just use the imaging that you already have, which is, when it's retrospective, you're stuck with that anyway. But it is also appealing. You do the same images in the same planes that you normally do, which means that you don't need other technical components to sort of get in the way, if you like.
So you show the reference from the sliced group.
Yes.
And I had to look into, do you know, it's a reliability study. And do you know what radiologists were part of that study?
No, I don't remember the names.
I think Taxdal should have been.
She should have been, yes.
But it was actually, I looked in it, so it's Kransdorf, Murph, and Vanel. So these are really famous, good radiologists. And the kappa was 0.345.
Yeah.
So what does that mean, that kappa, the kappa value is a reliability?
Yeah, I haven't done research on that yet, so I'm not, that is something I need to do and I need to learn. But essentially, I think as the value approaches 1, it is much more, you're much more in agreement. And the lower it is towards 0, then the less often you're in agreement, is my basic understanding.
Yeah, exactly. Yeah. So quite poor.
Yeah.
And still also, so it's, yeah.
But again, then I think in that article they tried to predict grade. That was their
benign
job.
versus malignant, or
so that was, and I think they were really important papers. These papers that looked at observer variability, this really basic concept. Are we talking about the same thing, both for pathology and for radiology, and also for clinical present assessment? This is done, and it shows that we're not talking the same language. We're not treating the same patients. But then the next step is we've got to do something about it. We've got to find another way of communicating and distinguishing these so that we can talk about the same patients, rather than just go on in the same track. We say, it's full of faults, but let's just keep going anyway.
Yeah, and there was a good conclusion in that study, like Lee touched here. Histopathologists also don't agree. So doing a biopsy, they won't agree on the grade, and you don't know where you took it. So like you said, we'll come back to that, but doing a biopsy, we don't need it.
No, we don't. And if anything, I think it probably can cause a lot of confusion. And in saying that, I have to say that this is in no way critique of pathologists. Pathologists have just got an impossible job, basically. They don't have the tools to be able to do the work that we hope that they do. And we think, pathologists, they're so intelligent, they look down the microscope, they can see or do all these fancy things and that, but they need the tools. And it's not critique of them, it's just we've got to sort of see the limits of the practice that we have together and find a way forward.
Yeah, I agree. We have to recognize that it's difficult. And so a little bit a technical issue from the article. You write, you measure to the nearest millimeter. Yeah. So why not lesser than that?
Just because in the technical software package that is practical, I guess, really. This is the sort of I can't remember the value. Does it maybe actually give it to 1 decimal point when you do? So I think it was just about practicality. You've got to sort of draw a line at some point. But yeah.
I think it's more of spatial resolution of the image. So we have to think about if you have like the voxels or the pixels like an image, they are all often 1 meter, 1 millimeter or a little bit larger.
Yeah.
So I would say that's the point.
Okay.
You can't measure within the voxel.
That's right. Okay.
And so always think that's good too. Yeah.
Good.
Technical. Yeah. So in your thesis, page 68, there's a figure in your thesis. So I'm going to be a little bit off his normal route here, so a little bit radiology.
Do you want me to just see this
is
here,
the image from your thesis, page 68?
Is this the examples?
Exactly, yeah.
I actually have that in
You've written too long, that's why.
I have it in a PowerPoint as well, but I can...
You're almost there.
Yeah.
Yeah, this
There.
one. Yeah.
Yeah, so the only thing is,
You can check. I don't need my presentation.
can put that down,
Yeah.
which is that one.
Yeah.
And then I pull that one there.
Yes.
You can see it. Yeah.
Super. So I always think it's important to, of course, to know what you're doing. So can you just explain what these sequences, what are different? Not in detail, but a T1 weighted image. What does that mean? What do we see in contrast, for example?
So the T1 and T2 are two sort of key variables. An MRI is not an MRI. So an MRI has a lot of different sequences that give us different information. And from what I understand, the T1 and T2 weighted images, the primary difference in that is that water content appears differently. So for the T2 weighted images, water content has this high intensity white signal that we have up here. And
correct. Yeah. And opposite in T1 is a fat weighted image. Okay. Yeah. Good. What people don't often know who aren't radiologists that we actually only look at fat and water, nothing else in regular MRI hydrogen.
It's brilliant in its simplicity and advanced nature at the same time. Yeah.
And the stir image up to the right.
Yeah. I don't actually know the technical difference from that. The part of these weighted images, this is important for the signaling of chondrosarcoma. So you can see on the T2 weighted image that the signal is typical of cartilage. But when it comes to the measuring of the size of something, we've said that you use just the sequence that best demonstrates your point. So we've not limited to measuring on only one series, as you can see here by 3 different ones. I'm not actually sure the technical difference for a stir image.
It's more of a fat-suppressed water image.
Right.
So how does chondrosarcoma look like on MRI? It has high signal on T2 weighted images.
Yeah.
Why is that?
Because it has high water content. So typically in the sort of MRI outside of a tumor center, that is looked upon as fluid, and they call it a cyst or a ganglion or something like that. So it's quite common to mistake it for fluid on outside of a tumor center.
It's interesting also how we have to specialize that you can make a diagnosis for cyst and it's actually a tumor. Yeah. And like you say, it's lobulated, popcorn-like.
Yeah, it has typical calcifications and also typical contrast enhancement curves and that sort of thing.
Yeah, good. Yes. Okay. Further down in the text, there was 91% untouched.
Yes.
And then you had 3% had a biopsy outside referral center, and 6% had contaminated surgeries. Did you have time to look into these 3 and 6%? Did you find any common denominator, or?
The common denominator, we were talking about whether these tumors are referred to a tumor center without a biopsy or operation, or whether they're referred what we call as virginous or as untouched. We talk about this tumor seeding or contamination that happens if you do things in the wrong manner. So the recurring thing is really that they don't understand that it's chondrosarcoma. So the recurring thing is that they think it is a myeloma or a breast cancer or something. And and either do a biopsy and say, oh, this was wrong, or in fact sometimes treat people without a biopsy and start radiation therapy or something like that, and really just make it all. But there's not many, there's very limited amount of, or hardly any operations that say, oh, this is a chondrosarcoma, let's go and have a look, try outside the tumor center. It's about misunderstanding the primary diagnosis from the first point.
Yeah, and the following question we touched, but you don't need a needle biopsy here, so you can see it's a chondrosarcoma.
This is, it's not about me, it's about the radiologists. So in my working with them, I try to understand their field because I think it's interesting and it helps me understand the tumor and give good patient care. But essentially, I would never dare to do this on my own. This is very much the work of a very specialized tumor radiologist. And this type of work outside of a tumor center, when you're really busy looking at rotator cuffs and hip arthritis and all sorts of other things, is not the same. So you've got to look at this in the context of our service, which is highly specialized, completely dedicated to this type of work, but in their hands, then we can be confident in doing this. We have, in fact, one mistake from this, but that is interesting, one which we biopsied. So this was a small periacetabular tumor, which had pretty typical signaling. We did a biopsy and got cartilage, so we said, well, this is a periacetabular chondrosarcoma, and we did a resection and a 3D printed prosthesis, and it turned out to be an inclusion cyst from, but we got cartilage from the joint. Oh. So in fact, in that point, it really just, yeah.
Yeah, it happens.
It happens, yeah, unfortunately. He's doing well.
I won't get in so much to statistics, but I noticed that you have Tor-Åge Myklebust as a friend. And I think it's super smart to have statisticians as a friend. Yeah. Because you really need good statistics to understand it. And he was actually in the BGC paper I saw that you showed, yeah.
Absolutely, yeah. So he is here, he's sitting up there. We've not been allowed to praise him enough, but I did a course in statistics as part of the PhD program, and one of his predecessors has written a big textbook on statistics, had the course. And I didn't understand a word of what he was talking about. And it was all about, oh, you don't need to understand, just do it. And it was very, very frustrating. And I met Tor-Åge, and Tor-Åge made me not feel stupid. So I was secure enough to ask questions. At the same time, he's allowed me to do the analysis and check the analysis so that I've been comfortable and had concepts that improve our research. So it's been really interesting, and hopefully we're going to do more work and uncover some more myths.
Yeah, good. I think we all find out after the PhD how much we need statistics. Yeah. We should have that more in medical school, etc. I think, really.
It's been key for my understanding. Previously, what you did is you gave your data to a statistician, and then he worked on it, and you got your curves back and your numbers back. And the university said very clearly that we need to stop this. We need to have you doing the work with guidance, and it is very key, I think, to understanding your numbers and your findings.
Good. You're really going deep into all this part of the PhD. I like that. Okay, we've seen figure 3A and 3B, but you can show it again in the paper 2 with the soft tissue.
With the curves?
Yeah, when you see the soft tissue versus...
That's in my presentation, isn't it?
Yeah. But because I understand that you got excited.
Yeah.
It's really nice to see those curves.
No one got offended by the Trumpism. That's the location, and that's that one or that one?
Yeah, it doesn't matter. It's so illustrative. An image really can show more than a text. You see this flat, almost like ECG, nothing happening there.
Flat lines are great, aren't they? Yeah. Sometimes, particularly when you have another line that's not flat. But the great thing is that we've started using this in our clinic. We've started changing our follow-up schemes for this. And for 80% of our patients, we can say that, okay, this is not validated, but we've looked at everyone over a 25-year period. And for 80% of the people coming in the door, we can say that, listen, this is okay. You're on a flat line. This is just life in general we can't do anything about. But for this, you don't need to worry.
Lovely. You're answering my questions before I ask them. But getting your research into the clinics, that's not that normal, I would say. Yeah.
I have a very enthusiastic boss in Ole Jakob. When he asked me to make up a chart for the new follow-up scheme. And when he got that chart, he said, finally your research is giving us a practical use. So he's been very good at implementing that. We've also involved Bergen, our colleagues on the West Coast, in that. They've been very open, so they're going to start following the same schemes, which is brilliant, and their data are obviously a big part of this information as well. And then we obviously need to validate and get this out.
With Birmingham, that sounds great. Then just want to discuss this 1 centimeter cutoff, or what we should call. But you write in your thesis, excuse my English, dichotomizing continuous variables can be highly problematic.
Yes, that's
and you have a reference Dawson.
Yeah.
But 1 centimeter, that's
doing exactly that.
Yeah. So can you just explain for us what's the problem and why do you still use it?
Absolutely. So basically, it's very well exemplified by this problem with size. So a number is obviously from 0 to something, it's an eternal sort of number of variants. And if you can analyze something as what's called a continuous variable, which is that all these options are a possibility. And for understanding size in a proper sense, then that is really methodically the best way of doing it. And we have found then that size, in fact, does not predict metastasis. But it's not practical. So how are you actually going to use something? We need something, particularly if there is something in that finding, to have some sort of cutoff. Now the problem, and there's various ways of doing these things. Sometimes you can just say 5 centimeters. Let's look at 5 centimeters and see what's more and what's less. Other times you can have a rationale to say that this in some way gives a critical change in the biology, and you at least need to have a theory. So making a continuous variables into a cutoff with groups is the only practical way, in essence, of using something. But it is then much better to either choose a mean variable or something, or preferably finding a variable where all the events are in the one group, which we've been lucky enough to find here. So but you're absolutely right. What I've had to do is what I've critiqued, and that is the typical thing, isn't it? You have a theory, and then the reality of it comes back, and you've got to use it all the same. But I think there's good and bad ways of doing it. So I hope I've found the best way possible to do it.
And like you also wrote, you tested for 1, 2, 3 centimeters. I like that as well. And when we're into that, you have written it, but I like that you try to find a plausible reason for 1 centimeter. And you write about and you say that you think it's when the periosteum, the thin on the bone, when it breaks through. Have you seen it have you looked into that, or is it?
Examining the periosteum is quite difficult with both in radiology and sometimes in pathology. But that's what we need to look at. I think what we're saying is that maybe 1 centimeter, when this bit has broken out through the hard bone, there's still periosteum or beinhinnen, which is a soft sort of membrane outside that tries to contain it. And maybe 1 centimeter is about the limit of strain that can manage before it gives way and the tumor also gets out beyond that. We know that the periosteum is a very good barrier to tumor growth, but it is obviously different in different areas and dependent on the speed of the tumor growth. So it can't be that simple, but there might be something in that is some sort of a type of a critical size for that. But we need to we haven't retraced the pathology specimens, but we need to work on standardizing the pathology forms for chondrosarcoma, and that might be a thing that we need to get in there.
And you can go with when you have the axial versus peripheral location. That you have an image in your presentation there to the right on some of the. This one, yeah.
Yep.
So you mentioned that. So why do you do it like that? You don't include the scapula, for example. What's the rationale between? I know you've written about, but tell us again.
Well, basically, when I sat down and read the chondrosarcoma literature to start with, I found it really confusing because I understood that people meant different things by location. We know that location, which bone it's in, matters. And basically, a lot of people use the words appendicular skeleton. And the appendage means obviously something that is added on. And this is wrongly written in the textbook we're supposed to follow. In the WHO textbook, they use the word appendicular, but what they mean is the extremity. So the shoulder blade is obviously part of the upper arm, but with regards to, and it essentially is part of the appendicular skeleton, strictly speaking. But we know that the biology of tumors in the scapula and in the pelvis are similar to the spine and the thorax with regards to their aggressiveness and with regards to their treatment. So they need to be in the right group. So with regards to this rate of metastasis that we can see in different locations, and obviously also with regards to the change of the skeleton and what the skeletal parts look like, that is the very sort of logical area to create a distinction. But it's done very variably.
And I'll keep on this subject. For example, as you know, if I said I have a cartilage tumor in a rib, you will never say enchondroma. No,
I will at least say to someone that nearly doesn't exist, and it is at least very difficult to differentiate. I think they did say that before. If you look at old textbooks, they have expanded rib lesions, but with highly differentiated cartilage, and they say, oh, this is an enchondroma. But the difficulty in that has been recognized and changed. So now we say, I don't think that is the truth either, that enchondromas or benign cartilage lesions can't exist in axial skeleton, but it's very, very rare, and you need to be very careful about it. So a group in Bologna have produced an article on curettage of very carefully selected cartilage lesions in the pelvis, which we traditionally say is dangerous and bad news. But what they don't do is they don't compare it to leaving them alone. So the solution probably for a lot of these patients that we're doing curettage for is actually probably doing nothing. And we need to observe patients without treatment to see whether that's probably the best option for many.
And now the next thing I've been thinking about, so why are the axial more malignant?
Yeah.
Have you any idea? Or
I've been thinking about it, and I've been talking to radiologists and oncologists and everyone about it. There is definitely a difference in the structure of the bone. Like we talked about my cortex in my tibia and femur and ilium. They have thinner bone marrow and thinner cortex. So maybe there is a degree of this. There's obviously a local issue with regards to margins and surgery and local recurrence, but there's also a systemic difference. And is that about the fact that long bones are just much better containers at containing tumors than in the axial skeleton? I don't know. Another thought is that this happens in the bone marrow. And in early life, we have red bone marrow in the extremities and in the pelvis and the axial skeleton. But in fact, as we turn into adults, the red bone marrow only retains in the axial skeleton. And this is an active bone marrow that produces blood cells and things. And so does that in some way entail also that it is closer to the circulation and in some way, and that tumors that occur in this red bone marrow is different to that which happens in sort of dormant yellow bone marrow in the extremities? I don't know, but it's interesting.
I've been thinking when I read about it, I think before, but I'm not sure. But what about how does a scapula ossify compared to humerus? Ossification of a bone.
Yeah, so I wrote about this in the start of the thesis, so they have different modes of ossification. That is how they develop from in childhood.
So it's endochondral humerus and it's intramembranous. I'm thinking if it's something, some reason. You want to comment?
Yeah.
So you shouldn't get cartilage in flat bones because they don't form from endosteal ossification. And there's just about to be a paper published from Birmingham that shows that the ratio of benign to malignant in the proximal femur is 1:1, whereas in the distal femur it's 1:11. And that's probably because 80% of the growth
happens distally.
Happens distally. So the cartilage that escapes is probably from the endochondral cartilage that then gets dragged into the femur, and that's why I think if you get cartilage in a flat bone, it's really bad because you should never have cartilage there in the first place.
But the implication of that, Lee, if I can call you that, is that that it's coming from the growth plate. Yeah. And obviously this was the sort of start theory that these come from where the bone grows, and the peripheral chondrosarcoma is proven that pretty elegantly, that the growth plate changes direction and forms this outgrowth. But for the central chondrosarcoma, finding that has been pretty difficult. And so I have to say that in some ways I find this concept, we have these stem cells in our bone marrow that we know can differentiate into cartilage. But then again, that wouldn't make sense that it happens in the area where you have more growth. So that's a really interesting finding, actually. Yeah, perfect.
Yeah, you're into my last question, but I have many more. This would have been my last question.
Okay.
Because I think it's also odd that you have secondary chondrosarcomas in the cartilage cap with this stem cell theory. It's very strange for me.
I think the peripheral chondrosarcoma is very clearly related to the growth plate, and I think again that is part of the difference to them. But the truth of that is not out there, and these findings are really interesting.
Interesting.
Yeah.
Very, very cool. Yes, you answer that, as of course. Welcome.
This is Silja. Hi.
Hello. Yes, and Lee touched that gender is, of course, important, but sometimes I feel it's not information that helps me so much.
No. What are you going to do about it?
Exactly.
Yeah.
And male sex had a significant independent predictor of local recurrence. And you also discuss it as well. What do you think? Is it because the gender, or is it a confounder?
I think this is random, I have to say. I sort of feel that this is random, that they have more men in this. We're dealing with small groups and small numbers. I don't understand why it should be. I mean, essentially, this is a type of staging tool. Is this a reflection of men not seeking medical attention later than women or something? I don't know, but the alternative to some explanation like that is more likely that it's random than it's biological.
And this is like about p-values and what's significant, and so if you have...
It seems wrong not to report it when I include it, but essentially I think the importance of age is to account for it. Age and sex are the sort of basic sort of parameters of health, so you need to correct for it, but I don't think it's really a significant finding. Statistically significant, but clinically not.
Exactly. So you touched that, but you implemented this in the clinic. So if a low-risk group actually has a grade 3 tumor, you will see it as a low-risk group as well, as I understand. Yeah,
we do.
That's very interesting.
It's a bit, if I can say, ballsy. It's a bit because, again, for all this time we've been saying grade is this answer, and what I'm sort of saying is that, well, I'm not going to weight it. I'm not going to believe it, and the height you can fall for taking a stance on something like that is pretty significant. So I do get a bit of a heart flutter once in a while when I think about the responsibility I'm taking, and my colleagues are, open and to my rationale about this. We've obviously done this for a good number of patients now and seen that it works. But we're taking a little risk in that, absolutely, and it causes draws attention.
Oh, good. So in table 2 there were 15 out of 103 that were grade 3 in the low risk group, actually.
Yeah.
So quite 15% almost.
Yeah.
A little bit more. Yeah.
Yeah. So that is. Those conversations were difficult to start with because you've got to find a way of formulating this. I think you've got to inform patients about this because we are reporting grade, and I think grade is definitely, there's something in it. So you've got to inform them that, and you're doing something different to everyone else. You've got to say that this is what we're doing, this is why we're doing it, this is our level of confidence in that. But those conversations are getting better.
Next thing that you write, and I'm not sure you're going to change how you do it in Norway, referral status, biopsy or surgery outside, like we talked about, sarcoma center, did not change it to a significant degree. So it didn't matter that you did a biopsy, and that's like the holy grail in sarcomas, untouched
So
lesions.
this was one of the reviewers that wanted this in. I think this is essentially because the numbers are so small that it's not significant, and that's a good thing. But you're right, we're going to keep doing things the way we're doing. We want them untouched.
And then I still come back to like the type 3 in the low risk group, that the actual cases with less than 1 centimeters.
Yes.
Yeah, that's kind of what you think about it. I think it is kind of interesting that one would think that the actuals are a little bit more malignant, but still if the soft tissue isn't more than 1 centimeter, it's low risk.
And again, I think that is also has been an uncomfortable stance to make, but at the same time, we've got this finding, and we could say that we're not going to do anything about this before it's validated. That would be an alternative way to do things. And I think you've got to accept there's a degree of uncertainty in things before things are validated. That is, it's been repeated in other cohorts. But at the same time, I think at some point you've got to say, well, we've got good data, we've done the work, and if we're not going to take the consequences of this, then, you know, when do you do it? If we're going to keep moving things forward, you have to make a stance on it. I think that is, again, we don't have huge numbers in these individual groups, so we need to respect that, but that's the stance that we've taken.
You're sticking to your guns.
Yeah. With nervous energy.
And okay, maybe we can skip that. Then you in table 4, and you touched that with Lee already. Low risk type 2 had no metastasis, but shorter disease-specific survival than type 1. And you touched it, but I think it's, yeah.
So this is the extremity lesions with big soft tissue components. They, if we look at these two graphs up here, they touch it really nicely. The one on the right is what's called overall survival, so this is death from any reason. Now you see that the brown line is following, the blue line is our high-risk group, and on this curve on the right, which you obviously can't see my finger, here, they're following each other, but we know that the one group is having lots of metastasis and the others aren't, so why is this? So if we use the alternative variable, disease-specific variable, it's not the same. But there is something happening with these patients that we don't know. They are older. They are probably more morbid. Is this an expression of other morbidity? I don't know. I have since learned that registry data can be linked to what's called the patient registry in Norway, so that we can extract comorbidity data from them. I didn't know that at the start, but I think that really needs to be a part of further calculations as well. And yeah, so I don't know exactly what's happening to that group with regards to overall survival.
Thanks. Yeah, then I've written here, so we shouldn't biopsy them. Could actually that we're improving the care, that you don't do biopsies, because you have this reference, and you touch a Barrientos-Ruiz biopsy versus open biopsy. So if we don't biopsy these tumors, we will have less contaminations. Maybe we're improving care.
It may be, yeah, absolutely. Even though a needle biopsy is much less contamination than an open biopsy, to taking a tissue sample as an operation, it is still a little bit of a contamination.
It's low actually. Yeah.
But it's low. But it's fantastic when you do an operation without a biopsy tract to not have to remove it, because it gets in the way and it's a pain, and it is, even if you plan it in a reference center like this, it's never quite where you want it, and it is a pain. So yeah, I think we're saving time, obviously. I don't think these patients have that short a time, but you save resources, you make things simpler. You're not in sort of bringing in another confusing situation in their care. And it's safe.
Spin-offs from this good thesis.
It has been documented safe in the extremity, but it hasn't really been documented for axial tumors. So the fact that we're not doing that is also a bit controversial. So we need to get that out there as well.
Okay, so I have to talk about McLaughlin. Just saying it, it's the reference about the lung metastasis.
Yes.
And I think Lee also touched it. All this study depends on metastasis. And then you show study that we overcall very many metastases. They aren't actual metastases. Could this affect this whole thesis?
It could do, but luckily I've gone in and sort of assessed all the metastatic variables. But I think if you use if you just use variables that are pre-recorded, you will have a tendency to over record metastatic events for sure. So I've basically followed a very similar to definition that he has had. If you have a small lesion but it doesn't progress, then it's not a metastasis. And this is obviously the hindsight of a retrospective evaluation, but I think it's really, really worthwhile. And these are the key events that drive our findings, so it's very important. And it sounds silly that we cannot be sure that someone has metastasis or spread, but even these things are actually quite difficult at times.
So I worked with the orthopedic surgeons in Stockholm, and I like they're trying to be funny but also pragmatic. Doing a normal X-ray of the lungs, it's smarter because you won't find these small nodules, and they only 8% of those moles are metastases. So
we've had a long discussion about this. If you note that in our numbers, people with metastasis, all of our patients with metastasis die. And you can either take that on as meaning that our true registration of metastasis is actually correct, and people otherwise saying, well, 40% live, or maybe don't have the correct variable. But if you're going to do something about that, what is the first thing that you're likely to do? Is to look harder for them. And we're going to do some CTs on these high-risk patients, but we've had a long discussion about it, and there's a clear possibility that we just increase the number of negative findings as compared to X-rays.
There are some guidelines, Fleischer guidelines for how to follow up on nodules. You can look it up.
Yeah.
That used by thoracic radiologists.
Perfect. I will.
Okay. And some soon we'll finish, but you also write, and this is the surgical margin independently predicts risk of local recurrence in line with intuitive thinking. I agree. What's intuition?
Intuition is complex. It is the basis of logic and learning and environment and lots of things. But I really enjoy going back and reading original articles, like you saw about Ewing. I always learn so much whenever I do it. Go back to the source. And I did the same in real detail with Evan's work, and his work was also just like, well, this is all about metastasis, and the local status is about whether you actually get the tumor out in one piece or not, and about treatment and margins, and so examining then grade as to local recurrence, it doesn't sort of make sense because it's not invented to try to find variables that predict it. And there's this really nice logic, and whenever logic matches up with statistics, then it's just like, oh, that's brilliant. It just makes for a good sleep. But I think intuitively, this is what we're doing. We're doing local treatment. Are we getting the margins that we need? Yes, and it shows in statistics, and that's brilliant.
Yeah, and I think it's proven in studies that intuition, complex decisions, you can trust your intuition if you have worked a lot, etc.
Yeah.
So don't underestimate intuition. But it's not from God. It's
no.
So, and just, you don't have to answer it, but you some reference to your using machine learning.
Yes.
So what do you think about AI and chondrosarcomas? Have you...
I think a lot about this, in fact. The artificial intelligence, I think it's interesting, but I think there's a lot of work to do done with data quality first. I think if you put poor data in, missing variables, then a machine's not going to be able to, and however how smart it isn't going to be able to compensate for that. So I think machine learning, absolutely, but we've got to have proper data first. And I think for the people that have been doing machine learning, artificial intelligence papers, they're using Sears data with missing variables, poor data quality, with all respect to them, but and I think that shows in their findings. It doesn't really take us anywhere.
I think the key issue have good data, and as you have shown, also we think differently, even experienced pathologists or radiologists or oncologists.
Yeah.
There's no gold standard.
No.
So machine learning requires a gold standard. So this is black, this is white, but we're working in the greys. So the machine can't learn unless you tell it it's black and white. But if we can't agree what a corner sarcoma is,
Exactly. How's it going to figure it out? Yeah.
Yeah. So, and in your thesis, you don't have to take it up, but on page 30, you write capital letters, not reliably differentiate. And it's about diffusion-weighted imaging and PET-CT. And like you have capital letters.
The whole thesis is quite informal, which is my manner. And my colleagues have all read through, and they've all got a PhD, and the PhD form is quite formal. So that was a bit difficult for them. But luckily, part of our PhD had a course in writing with a French chap called, or American chap called Phil Levenstall, living in France. And he was all about finding your voice. And for me to write in any other manner than that just seems, I just lose a lot of the meaning if I don't express myself in the manner that's natural to me. So we...
I like that. Like I said, there's a personal tone in it.
Okay.
And still, it's 100% scientific and a personal tone. That's cool.
I think there was a bit of disappointment in the knot as well, because we all want this MR sequence, which is going to give us this whole answer. But, yeah.
And the co-author of that paper is actually in this room.
Really?
Yeah. This is Jace.
You're everywhere.
Yeah.
Yeah.
So they shown that it
didn't know.
doesn't work. So it's a really good paper showing negative results. I love that. We need more of that.
Yeah.
What you know about diffusion-weighted imaging?
Even less than it's even less than
Jace?
for perfusion, but it's about Brownian motion of water particles or something. Yeah.
Yeah, exactly. This is the
Wikipedia
essential
told me
always. What are we looking at? So it's the water molecules moving.
Yeah.
And if you have a high cell density, the extracellular volume gets smaller.
Right.
And they can't vibrate.
Right.
And that's why they get higher, low ADC or increased diffusion, decreased diffusion. Yeah, I like that paper. But we have to try these new techniques. Yeah.
Absolutely.
And Evans, you talked about from 1977, probably the most second important chondrosarcoma paper. No, after yours now. And this just, I would say, final question. I won't go into pain. But it's not pain here still. But paper from Chang, 2018, about regression of tumor. Can you explain to me how a tumor can get smaller without treatment? So there's a paper. Yeah, you can.
There is one paper. Is it Chinese or it's Asian at least? Which follows observed enchondromas, the benign cartilage lesions inside the bone, and basically they find that up to 50% get smaller. Now I have to say that we follow a lot of these and we don't see that, so it's a bit surprising. But I mean, these things we also see sometimes. We tell people that anything that gets smaller can't be dangerous. Okay, bad things get bigger, small things get better, but the body is obviously complex, and in what the activities of a bone marrow, of what it can do with regards to immune cells and all this type of thing is not understood perfectly. But I don't know, but we've not seen that ourselves, I have to say.
I agree. I had to look into it, and they also classify when it gets more fatty.
Yeah.
So probably it's bone marrow within these enchondroma, etc.,
Yeah.
infiltrating. But it's strange. But stranger papers have been published.
But we have seen enchondromas that disappear, and we've also seen osteochondromas that disappear. And things that you traditionally say to people, that doesn't happen. It does happen, but very, very rarely.
Okay. Yes, so I'll finish up with, in page 44, you write, CT and MRI has indeed revolutionized chondrosarcoma care.
Yeah.
So.
And I think the amount of planning we can do now because of both the technology and the understanding of how to interpret them. Again, if you read the old sarcoma literature, they grade sarcoma treatment on the number of operations. So you didn't have these scans where you could determine or know already what muscle it's in. You had to go to the patient, you had to move them about and say, oh, I think it's probably in this muscle. And you went and did your surgery and you took your tissue, you sent it to the pathologist and they said, no, there's lots of tumor in the margin here, you have to go and do another operation. And you did another operation and a third or a fourth until you got, oh, there's no more tumor tissue. And so it was common practice to sort of grade sarcoma practice in the number of operations. And there's a great SSG article from Tor Alvedal, is that his name? Who has this as the outcome measure, if you like. So the world is really getting on, and as you start using something, you can't investigate it afterwards. But I think with regards to the precision that we can do things, it's just key.
Yeah, and like Lee is doing, and you are doing this with navigation. If you can look into something before you go there, it's so clever. Okay, thank you. I'm pleased.
Thank you so much, Mikael.
Thank you, Mikael. Many studies I haven't read probably show that we need a short break so the brain can rest a little bit.
Yes.
So we can come back in 10 minutes and Professor Jace will finish this dissertation.
Yeah.
Finish him off.
Yes. Så bra. Det er gøy, altså.
It's worth doing. You spent 8 years doing it.
Oh,
It's
yeah,
good to
absolutely.
talk about it.
It's
Because
funny.
nobody else will listen to you. So.
Nobody else will. We've got to put them, and it's amazing how much time you actually spend thinking about this discussion and this day.
Yeah.
So it's good. Have you got yours? It's probably behind that if you just close. Yeah.
I didn't realise you could see the next one coming up. That's cheating, huh?
You can make it smaller. I saw actually Mikael had one with a humor. For de har ikke en sånn lader her, skjønner du, så det er det jeg ikke helt skjønner. Men det er batterier eventuelt. Hvis vi kan åpne den, så er det batterier her.
Ja, det er jo mange som sånne. Det er ganske...
Jeg skjønner jo det.
Ja.
Veldig bra.
En lang seanse.
Ja. Hvis jeg hører disse historiene om disse gamle fagene med sånn mange timer, det er jo helt absurd. Man blir jo ikke veldig mye klokere av det, men...
Nei, men jeg storkoser meg. Jeg synes det er kjempekoselig og morsomt å høre på.
Ja, så bra. Nydelig. Det er jo masse... Dette gjelder jo mange av våre pasienter også. Det er veldig like ting.
Så det er klart, men det er jo ikke alle som er så nerds da. Så.
Ja, men jeg er glad for at du er så nerdete.
Ja.
Veldig bra.
Okay. Professor Jace, are you ready to...
Okay, so it's nearly 3 o'clock. You get an extra 4 minutes by that clock. So for the gentlemen in the audience with slightly enlarged prostates, and for anybody of my age over 50, if we're going out tonight, then we need to have a nap about 4 o'clock. So I'll keep this brief. You've already demonstrated a very sound knowledge of your subject, and I've got a million questions. I'm sure we'll carry on talking about it all night, like boring old men that I am. So we'll try and keep this briefer. So, simple question. Should we correct grade 1 chondrosarcomas, even though you don't like grading?
In the extremity or in general? I am very tempted to say that we should just stop doing it and observe them.
Okay.
And I think that's nearly what we were doing. And I'm very much looking forward to doing up that material. But I have a feeling that what we're really doing with this is treating patients unnecessarily.
Okay.
Now, I can't say that is correct, but it's an interesting
I agree. I don't think there's a role for intralesional treatment of cancer. So it's either cancer or it's not cancer. But that brings us on to your Oslo grading. And would you correct a low risk, less than 1 centimetre soft tissue mass, or would you excise that with a margin? Yeah,
anything with a soft tissue component, I would pretty much advise resection with a margin. The context of this, again, is the treatment that has been given. And I think with regards to local recurrence and this sort of thing, the curettage for things with a soft tissue component don't go well. And I would be very hard pressed by a patient to do anything but a resection for something with a soft tissue component.
Okay, good. So what is the fear, what is our fear of doing an intralesional treatment for what appears to be a low-grade tumour, so even an intraosseous tumour?
Our fear is that that we're not doing big enough surgery. I guess it's all about that we're not doing safe enough surgery for that patient.
By what reason, though? What is the fundamental of it? By you say not doing safe surgery?
Yeah, that the tumor is going to reappear, keep growing, and that a next type of surgery is not going to be able to, for example, retain the limb or something like that. The consequences is going to be bigger surgery later.
So the paper 3 is all about local recurrence, isn't it?
Yep.
So we're worried all the series of intralesional treatments, even for grade 1, show a recurrence rate of somewhere between 25 and 30%.
Yep.
Your thesis showed that for curettage there's a 25% local recurrence rate. Local recurrence is not so much of a concern, as you said. Most of them are incidental, picked up on scans. But one of the fears, and this is where we're going to get into the controversy, I think, in your thesis,
Yep.
which is around upgrading of local recurrence. So there is Frank Sims' paper talked about a 15% rate of upgrading. Your paper, interestingly, shows that there was not very many cases of upgrading.
No. I think, first of all, people define upgradingly different. I think in the original papers from Sim and these people, they combined de-differentiation with upgrading. So they're both using upgrading. That is, something has been changed from grade 1 to 2 to 3. But they're also including all the cases that come to their institution as de-differentiation as a sign of upgrading. And that, so in the fact, their actual percent that changes was only 3%.
Yeah.
Yeah.
So your premise is that de-differentiation is a separate disease to ACTs or lower grade chondrosarcomas.
Yeah. When de-differentiation occurs, we're no longer really treating the chondroid tissue. It's the other tissue on part which is dictating the biology.
But do you believe that a grade 1 chondrosarcoma can become a grade 2 chondrosarcoma that become a grade 3 that can be then de-differentiate?
I think these tumors can change, and I think they have a stepwise progression, and you can call it grade or you can call it stepwise progression. But I think it is. I think the actual biological activity of that is much less than what we're seeing in grade.
Okay. Do we see that in other tumor types?
Not so much in other sarcomas that I can think of.
Not carcinomas. Do we see areas of clone? What I'm trying to get to is clonal cells. So do you think that clonal cells happen in chondrosarcoma? Do you think we have? I showed you within the same tumor, intratumoral heterogeneity, that you've predominantly grade 1, but a small focus grade 2.
Yeah.
So do you think that small focus grade 2 being more biologically active then makes that more of the tumor is grade 2? And then do you think those can become even more than grade 2 and then become grade 3?
I don't have much experience with any other tumor types than that. It wouldn't surprise me if that is the case, but I think, wouldn't be able to answer that specifically.
Yeah.
I think, again, that it's possible that this is a part of chondrosarcoma progression, but I think we can still use staging to decide when it's a problem or not.
Okay. So we talked about grade before, and you obviously are not such a fan of grade, which I perfectly understand.
Yeah.
But you talked right in your first lecture about what a grade was.
Yeah.
So tell the audience again, remind them how we determine what a grade of a tumour is.
So by the original sort of classification, the pathologist sat down and said, what features do we think correlates with this disease metastasizing? And they took probably some features that first of all, he saw in these 70 cases that he was looking at, and probably also conferred other things from other types of tumor situations. So he was talking about the nucleus, which is the sort of brain or computer of the cell. If this is larger or different, then that is correlated to disease aggressiveness in a lot of situations. He looked at the cellularity, basically just how dense the cells are. He looked at what's called binucleate cells, which is this, and which is also from other disease correlated with aggressive features. He looked at the background, whether it is myxoid, which is more like not cartilage, but more like slime-like. And he also looked at mitosis.
So what you're telling me is, looking at dead cells, we're looking for features within those cells that would denote that they're not acting normally. So they're more rapidly dividing.
They're deranged and more rapidly
They're deranged in variety. Yeah. And when we get to de-differentiation, the cartilage has stopped looking like cartilage and started looking like bone, osteosarcoma, or things like that. So that brings us back to, you talked about local recurrence, and we'll get onto that in a second. being important but maybe not important, and metastatic. How like the primary tumour cells do you believe that metastatic cells are? Are they the same cells or are they different cells? And tell me why you believe what you believe.
Ooh, I've not thought about that actually. I've just been explaining to my mum that the metastatic cells are the same as the primary tumor with regards to terminology.